So we're good now?
Yeah.
Okay, we'll get started. So, once this is out, please feel free to get up and get some lunch during the seminar. Would that be okay
of course.
with you? Okay, all right.
I think a well-fed audience.
Yeah, and then they won't ask you grumpy
Yeah,
questions.
right,
Oh, yeah. There you go. So it is my pleasure today to introduce Ashley Felix. Ashley Felix actually got an undergraduate degree in public health from Johns Hopkins, went on to get her MPH at the University of Michigan, and then her PhD at the University of Pittsburgh. She followed this up with a postdoctoral fellowship in cancer prevention at the National Cancer Institute, and now is at The Ohio State University. She's an associate professor of epidemiology in their College of Public Health. And she is also a member of the Cancer Control Program. I think that's the name of it, Cancer Control Program at the James Comprehensive Cancer Center. So I've known, we really didn't figure this out at lunch, but somewhere between 10 and 15 years now, I've known Ashley because we are still part of the epidemiology of endometrial cancer consortium, E2C2. And so I'm really here, delighted that she's going to tell us some about her research, and she's going to be talking about endometrial cancer. Although she has an overall interest in, I would say, molecular epidemiology of gynecologic malignancies, and biomarkers associated with that, both to the cancer etiology and survival. She has a specific interest in endometrial cancer, and today she will be speaking on understanding and addressing endometrial cancer treatment disparities. So, turn that over to you. And again, please get some, I think, things, I'm going to open these up so people can get some food.
Well, hi everyone. Thank you for having me. As Linda mentioned yesterday, I feel like we know each other from another life almost, but it's really nice to reconnect and be here. And the meetings have been so great. Like, everybody has such different and interesting research, and so I feel like I'm learning a lot here. So I would say, like, I always struggle with how to introduce myself. I don't know. So I thought I would do something a little different, since Linda already mentioned where I've done my training and all of that. But I kind of wanted to tell you about who I am as a person. So I'm from Pittsburgh, Pennsylvania, and so this is like one of my favorite views of Pittsburgh. So this is like the Allegheny River and the Monongahela River. That's where they meet to form the Ohio River. But I'm a Pittsburgher. We feel like we're Midwesterners. I don't know that we actually are considered the Midwest, but Pittsburgh's a lovely place to live, and it's just, I always feel like very strongly connected to my hometown. I'm also a mom, so I have a 3.5-year-old Eden, who is just hilarious, and then also have a 1-year-old Arden. So I'm a nerd. I named my girls Eden and Arden, but my husband's always like, "Did you want to always confuse their names?" But yes, that's exactly right. But in addition to our human kids that we take care of, we so where we live in Columbus, we live on some land, and so we have some other children that we take care of. So this is Amanda Swine, this is Smile Richie, this is Jacob Gotenhall, and then this is Benjamin Mutton. So my husband is very into puns, if you cannot tell. But really I bring this up just because I feel like I'm sort of like a reluctant nature enthusiast now, just because, we live like in a really rural area, we live on 8 acres, and so it's fun. I feel like what you do outside of work is also really important. I know those of us in this room, we do work on cancer. It's kind of a heavy topic, and I think for those of us who do disparities work, living in that world every day is pretty heavy. And so I definitely have a lot of things that I like to do outside of work that sort of give me some more work-life balance. And then there's he's the very first kid that we ever had, Waldo. He's a couch potato, like the rest of us. But all to say, this is just a little bit of who I am as a person. And yeah. Okay, so here is an outline of what I plan to discuss today. So I'm going to start by introducing the framework that guides my thinking in terms of the analysis of treatment disparities, particularly in the context of endometrial cancer. I'll then give some background on endometrial cancer with a focus on the manifestation of racial disparities that characterize this malignancy. And then I'll finally get to some empirical data that my group has done related to racial disparities in the receipt of guideline concordant treatment as well as where I'm taking this specific area of my research program. Usually when I give these sorts of talks, I like to sort of be like more broad and talk about like a lot of different areas that I've worked in, but like this topic is so consuming in my mind. And so even though I just did finish my K related to molecular differences in adiposity and how weight change affects inflammation in Black and white women, which is a super interesting topic too, I wanted to stay focused, and I talk about things related to treatment. So the framework that I like to use comes from the 2002 Unequal Treatment Report from the National Academy of Medicine, which is formerly the Institute of Medicine. And in this report, they outlined their preferred conceptual and analytical framework for research regarding racial and ethnic differences in healthcare specific outcomes. So here in this graph, I'm demonstrating the typical way that I think about racial disparities. And this is specifically applicable to my scope of research, where we look at endometrial cancer treatment rates or proportions. And here you can see in this figure that the white group has higher rates of endometrial cancer treatment than the Black group. So this represents the total difference in treatment rates or proportions, whatever the measure is that you're looking at, between white and Black women with endometrial cancer. And then the cause of this mathematical difference is unclear. The National Academy of Medicine framework then parses out reasons for racial and ethnic differences into the following 3 categories. So this first category includes factors deemed as allowable sources of treatment differences. Or said another way, if the reasons for that mathematical difference in treatment rates between white and Black women are due to factors in that first box, we might not think of these as actually rising to the level of disparity per se. And so what example that you might think of with this is, so patient treatment preferences. So if the reason for the difference is that Black women are fully informed of their treatment options and they prefer to not have treatment, then this wouldn't rise to the level of a disparity per se. The second category includes reasons that have to do with the systemic level policies and like the legal realities in which healthcare systems operate and provide care. And these include factors like provider density, so where our providers are actually available to provide care, and things like local practice patterns. And then the third category includes reasons for treatment differences that might stem from interpersonal racism, interpersonal level racism on the part of providers. So examples here include implicit bias or discrimination via incompatible communication styles as examples. And then together, the National Academy of Medicine framework deems these 2 sources here as unallowable sources of differences. And so basically, if these are the reasons that are causing that mathematical difference in treatment rates between white and Black women, we might suspect that the healthcare system is culpable or responsible for the existence of these disparities. So I like this framework quite a bit because it's really helpful in allowing some standardization between studies in terms of what we're talking about when we're saying disparities. And it really attempts to specify normal values about what factors might cause differences in health outcomes as opposed to what factors are actually driving disparities. So again, I think the take home here is that not everything should be considered a cause of disparities. The caveat that I want to make here is that the work that I'm going to present today actually doesn't do a great job of addressing these higher level sources of disparities that I've highlighted here. But I want you to keep this in mind sort of, because I'll talk about it a little bit throughout the presentation, but I'll come back to it at the end when I get to talking about our future research and how we're trying to incorporate this multi-level framework to understand disparities. So I'm curious how, I mean, I know that Linda is a gynecologic cancer researcher, but I'm curious like how, I guess I can't really tailor this at this point, but I wonder if people are familiar with endometrial cancer at this point. Okay, well, so the malignancy that I focus on is endometrial cancer, which is the most common gynecologic malignancy in the United States. So the endometrium here, it's just the epithelial lining of the uterus. And approximately 90% of all uterine cancers arise in the endometrium. So in terms of incidence and mortality, in 2023, about 66,000 cases are expected, which is greater than the incidence of all other gynecologic cancers combined. So think about cervical, fallopian, ovarian, vulvar, and vaginal cancers combined. In terms of mortality, approximately 13,000 deaths are expected. And so you'll see a lot of times, like on like the SEER FAST stats page, you'll see that they report that the mortality rate is about 5 per 100,000 women. I'm just mentioning that here because you're going to see some rates that don't line up with that. So just mentioning that here. But overall, we would say that this is probably a low mortality rate associated with this malignancy. However, stark racial disparities in mortality from this disease exist. Okay, so I'm going to start with a takeaway here, which is that Black women with endometrial cancer are more likely to die than women of other racial ethnic groups. So the figure and corresponding table are from a recent publication from Megan Clark and her group at NCI, where they use data from the Surveillance, Epidemiology, and Results Program to evaluate endometrial cancer mortality rates by race and ethnicity, both uncorrected for hysterectomy and corrected for hysterectomy. So panel A is showing you the uncorrected mortality rates and panel B is corrected. So rates for Black women are shown in this. Are you gonna see my cursor? Yeah, I'll just use this pointer. This work. Okay, well, rates for Black women are.
Sorry about that.
No, it's probably not. Like I was telling Brian, I'm very technologically. Anyway, the rates for Black women are shown in this like navy blue line here, and so you can see that like regardless of whether we're looking at the uncorrected or the corrected rates, mortality rates among Black women are twice as high when compared with white women. So with respect to trends over time, again, this might be a little bit hard to see, but if we just focus on the hysterectomy corrected mortality rates in panel B, you can see that over time, mortality is increasing significantly for white women, which we're showing this here in this orange line, as well as significantly increasing for Hispanic women, which are this is characterized by this blue line. So it seems like mortality rates are somewhat stable among Black women and among Asian women. I'm going to also pause here just so because I feel like sometimes people they prefer graphs to the actual data in a table, but I'm going to pause here so that you can sort of appreciate what's in the table as well. So the second column is the hysterectomy corrected mortality rates according to race, and this is expressed per 100,000 woman years. So again, I think you get a sense of like what this disparity looks like here. And I should note that the racial and ethnic disparities in endometrial cancer are probably, I think they're the worst of all solid tumors. So I'm pretty sure that there's no other solid cancer tumor site where the mortality disparities are this pronounced.
So the incidence rates look the same?
So incidence rates, I mean, they're increasing for all women. What has been historical for endometrial cancer is actually that incidence was higher in white women, but than compared to other racial ethnic groups. But what's happened recently is that there's been Black women and other minority groups have basically caught up to white women in terms of incidence. But also the other really interesting thing with incidence is like what types of tumors are developing. So we're seeing more of the really aggressive tumors in terms of increases in incidence. But Megan also has another really good paper on just incidence and survival, but with really nice figures as well. So undoubtedly, one of the most important contributors to racial disparities in mortality is the observation that Black women are more commonly diagnosed with aggressive forms of endometrial cancer. And so I'm presenting data for multiple racial groups here, so non-Hispanic white, Hispanic, Asian, and non-Hispanic Black. Probably you've already like gleaned from the way I'm talking about this. I think it's important to present the information for all women, but really what I'm focusing on in my work is really the Black-white comparison. But so, okay, this figure is showing us the stage distribution of endometrial cancer, comparing these four groups of women. And these data were pulled from the SEER 17 registries for women who were diagnosed between 2000 and 2020. And so basically what you can see, hopefully, is that, so I've only presented the proportions for white and Black women. So we see that among white women, 73% are diagnosed with a localized tumor, which is really good for prognosis, compared to only 58% of Black women who are diagnosed with localized tumors. And then you can see that Black women have a higher proportion of being, a higher likelihood of being diagnosed, well, I shouldn't say likelihood. There's a greater proportion of Black women who are diagnosed with regional and distant stage tumors compared to the other racial and ethnic groups. Of course, I am just showing you the unadjusted frequencies, but these relationships do hold up in multivariable adjusted analyses. And so then the other, so when we think about aggressive disease, like we really a lot of times think about stage and histology and the molecular subtype. I'm not going to show any data related to molecular subtypes, since, well, I'm not going to show any of that data, but so in terms of histology, which again is very important in terms of survival, we can see that Black women have a lower frequency of developing these tumors that are listed here first. So these are low-grade endometrioid. So these typically arise in a setting of unopposed estrogen. They're pretty indolent. Women do pretty well after they are diagnosed with them. So you can see that, oops, sorry guys, but 68% of non-Hispanic white women are diagnosed with low-grade endometrioid compared to 42% of Black women. And then really the remaining tumor subtypes that are listed, these are all pretty aggressive in terms of mortality. And so really pointing out what's going on with the serous and the carcinosarcoma, you see that Black women have a higher proportion of tumors that are diagnosed as serous and carcinosarcoma. And again, these patterns have been shown in like a variety of different types of epidemiological data, and these patterns are really often cited as to why Black women have mortality rates that are twice as high as white women. But of course, aggressive disease is not the sole reason for racially disparate mortality, and that is evident because even when we look within subgroups characterized by these tumor characteristics, we still see that Black women have poorer outcomes. So this is the paper that I mentioned a second ago. This is Megan's incidence and survival paper using the same data set, so using SEER data. And so basically she's focused on on the y-axis, you can see that she's focused on 5-year relative survival. And so she's parsed this out by stage, and what you can't see here is that this is restricted to women with non-endometrioid tumors. So if you think back to the previous slide, it's really women with those aggressive tumors. So within these subgroups, again, we're seeing that Black women who are shown here in the red bars, they have lower 5-year survival proportions compared to women of other race ethnic groups. And then this pattern continues for regional stage tumors and distant stage tumors. And I just want to mention that, pictured here is the non-endometrioid subtype, but the patterns look very similar for endometrioid and sarcomas, which are basically just like the broad categories of endometrial cancer. So apart from tumor characteristics, I'm kind of skipping a lot here, and I like to do this in my class as well. I don't think I do a good job of like putting in the right amount of content for the time, and it's not really doesn't matter when you're teaching because you can just go to the next class and it's fine. But I might sort of edit some of the things that I talk about in depth. Sorry about that. But apart from tumor characteristics, there are other factors that likely contribute to racial disparities in endometrial cancer outcomes. And for the purposes of today's presentation, I'm just focusing here on unequal treatment patterns. So as you can imagine, there have been quite a few studies on racial disparities in endometrial cancer treatment, and thinking about the decades of work that have been done and trying to distill like what is the picture, what do we see? For the most part, I would say that we do see that Black women have lower rates of various types of endometrial cancer treatment. So for endometrial cancer treatment, women can have surgery, radiation, chemotherapy, and more recently, immunotherapy has been introduced for the management of endometrial cancer. But there are some conflicting data as to whether Black-white differences exist. But I guess when I see those sorts of, when I see that sort of data, I really think that it's like methodological differences in the approach that are driving that. I don't think it's actually a true question of whether disparities exist or not. But really there are differences in whether studies report prevalence estimates versus multivariable adjusted estimates. And so really the importance of confounding is a key question there. These questions about treatment disparities have mainly been addressed in single institution studies, which sometimes have low sample sizes, which then translates to very low numbers of Black women. And so that's been a challenge for single institution studies. But then With those types of studies, there also might be important trends in physician treatment patterns and preferences that are more so related to the hospital setting that we're not really capturing in the data. Differences in treatment ascertainment across studies make comparability difficult. And finally, most studies include heterogeneous study populations in terms of tumor characteristics, which of course is really important when we're thinking about treatment and how analyses of treatment disparities really should be conducted. So I'm going to come back to that last point in a minute, but I kind of want to take a quick detour to talk about the National Comprehensive Cancer Network treatment guidelines for endometrial cancer. So again, I feel like I've been a little bit vague in terms of talking about what treatment is for endometrial cancer, but again, it's surgery, radiation, chemotherapy, and immunotherapy. And I would say that for the most part, the literature focuses on trying to understand if there are disparities in individual components of the treatment pathway for women with endometrial cancer. So are there disparities in surgery? Are there disparities in chemo? Are there disparities in radiation? So in my more recent work, I've been, I wouldn't say arguing, but I would argue that the paradigm of exploring treatment disparities should shift to focus on a conceptualization of treatment as guideline concordant versus guideline discordant. So here I'm showing you the treatment that should be selected for a woman with endometrial cancer. And you can see that this depends on both the stage and histology. So in this example, women with non-endometrial histology from the biopsy should have a total hysterectomy with removal of the fallopian tubes and ovaries. And then once that surgery occurs, dependent on her stage, she would have these different treatment options. And so what's important here, again, is the entire treatment pathway, because that's what the evidence is based on, right? So in our clinical trials, like, we're not just looking at these things in solitude, we're looking at the whole treatment pathway for these women. I feel like I'm sort of trying to like beat a dead horse here, but like I think that like the idea that we can just look at whether or not there are differences in surgery or radiation, if that would tell us that there's a disparity, it's not really getting at quality of care, it's more so getting at quantity of care. And you can imagine that like maybe some women are getting radiation, yes, that's great, but maybe they should not be getting radiation due to their cancer, their tumor characteristics. And you could think of that also being related to poor outcomes. So you're kind of thinking, I think of it as like inappropriate treatment based on the tumor characteristics. And then this gets back to the clinical appropriateness part of the National Academy of Medicine framing. And so I would say that based on the underlying, the differences in tumor characteristics, which I already showed you, right? So we know that Black women have higher proportions of later stage of diagnosis, aggressive histology. Based on this, we should expect the opposite, right? We should expect that Black women are getting more treatment than white women. So in the scenario where they're getting less, like this, it seems like very much so to be not the way that we should be treating women. And so again, I would just say, oh, I'm gonna go back one, sorry about that. And so if we're classifying treatment as guideline concordant or not, and then we observe racial differences, this should more clearly signal disparate quality of care. They may have any questions at this point. I know I talk quickly. My students tell me this all the time. Go ahead.
It's not so much a question as a comment, because in some ways, based on what you're saying, you would actually expect us to be making another argument around that the allowable differences would actually show a disparity in the other direction, wouldn't they?
So give me
where the Black woman would actually be having superior outcomes potentially, or greater treatment versus the white women, and that would be an allowable and treatment concordant difference.
But
am I making sense?
Well, if you keep going, maybe I feel like I'm not following, but that's me probably. But so okay, so when looking at the allowable sources,
we should actually see higher rates of treatment of Black women based on diagnosis, and that might be an allowable difference. So basically, this picture is doubly underrepresenting the disparity.
Okay.
Because the okay, I promise I'll try to get there quickly. Because you would actually expect the gray bar to be higher in terms of treatment based on the
Sure, sure.
characteristics that are allowable.
Sure.
Therefore, then the allowable difference becomes less treatment for the white women in
Yeah.
this case. And so just trying to get them to the same level is still a disparity because it's not taking into account
Right.
the other parameters that would be indicating that would be appropriate treatment for that group of women.
Yeah, I'm following you.
Okay.
Yeah, no, I think, yeah.
Copy.
Did you wanna come, no, I'm kidding. No, thank you, no, I think that's a really good
I think
comment.
I have a much simpler question. Sorry, Dee.
Yeah.
You might have said this early on, but the black and white, the gray and the black bars, is the difference treatment yes versus no, or different, or is it treatment sort of treatment?
Yeah,
Like, what is that difference?
sure, yeah, I'm sort of trying to make this like as simple as possible. I would think about it as like, you could sort of substitute here, so endometrial cancer treatment, like endometrial cancer surgery rate, or endometrial cancer, like, but this is the pattern that we always see in the literature, right? We're always seeing that, whether it's odds of treatment, whether it's whatever, we're seeing like higher rates in the white group compared to the black group.
But the difference is, if there's no, it's either yes, they had treatment, or they did not have treatment at all. Is
Well,
that what that's looking at?
sure, but it kind of depends on which treatment we're talking about, but this was just supposed to be a generic like representation of like just how I see
Okay.
disparities with respect to treatment.
Okay. Thank you.
No, thanks. Yeah.
Kind of easier. Sorry, Jamie.
Okay, so kind of switching gears and like moving on to actual data that we've used to address these questions. So the two data sets that I've used to look at predictors of guideline concordant endometrial cancer treatment are the Women's Health Initiative, specifically the Life and Longevity After Cancer cohort, which is known as LILAC, as well as the National Cancer Database. So a little background about LILAC. So this is an ancillary study from the WHI, which involved women who developed one of these 8 cancers that are shown here on the bottom of, I don't know how I'm doing this with my cursor, you guys can't see that, but yes, one of the 8 cancers that are shown at the bottom. And basically, women in LILAC, they completed baseline and annual follow-up surveys, and then cancer treatment and outcomes data. This was a little bit complicated, but they were derived from Medicare data, direct medical record abstraction, and then when the former sources were unavailable, they used self-reported data from cancer survivors. So this kind of gets back to the problem that I mentioned before, that there's like heterogeneous treatment ascertainment methods that like I think are important in terms of trying to identify disparities in treatment. But for my analysis, I focused on those women with endometrial cancer. And so yeah, it's a small group of women that are in LILAC, so it's 648, or actually I couldn't even see the number, but so again, so this study was funded through a diversity supplement from Electra's, so Electra Pasquet is one of my mentors, and so this was a diversity supplement funded from one of her grants. And the broad goal of the supplement was just to examine predictors of guideline concordant treatment and examine associations between guideline concordant treatment and survival. And so we ended up including 629 women with endometrial cancer. You can see a really low number of Black women in this study. So we, in terms of just looking at the proportions of women who received guideline concordant treatment, we saw that 84.2% of white women received guideline concordant treatment, compared with 69.2% of Black women. So again, we're seeing lower treatment in the minority group. So in the logistic regression, we observed lower odds of guideline concordant treatment. However, of course, the confidence interval includes 1, likely due to the low number of Black women that we were able to include in this analysis. But in terms of survival, we observed improved survival in a multivariable model. And you know, again, the effect estimate contains 1, but again, I think that we're working with a smaller study population here, but I would say that this like really got me started down the path of like wanting to understand guideline concordant treatment, particularly in larger data sets that are more well powered. And so the next 2 studies that I'll tell you about were conducted within the National Cancer Database, which I'm sure people here are familiar with. It's a much larger data set based of cancer registry data. So, but in case you're unfamiliar with this data source, it is a hospital-based cancer registry that includes data from over 1,400 facilities that are accredited by the American College of Surgeons Commission on Cancer, and it represents approximately 70% of all newly diagnosed invasive cancers in the United States. So it's a really great resource, particularly, I mean, I feel like there are some many trainees here, and I think when you're starting an academic position and you don't have your own data just like ready to go and you're starting to collect data, it's really great to be able to use these existing resources to come up with questions. But anyway, so the variables that are available, so it includes things like socio-demographic characteristics, tumor characteristics, facility characteristics, first course of treatment, which is important for this study, and then overall survival. And then in terms of the analyses for both of the studies that I'm going to show you, we use logistic regression to look at odds of guideline concordant treatment receipt according to race, both with race and primary exposure, and Cox proportional hazards regression for associations between guideline concordant treatment receipt and overall survival. I should mention in this data set, they don't have cause of death data or recurrence, and so you're kind of limited into what you look at for your outcomes. But anyway, we looked at this in the overall study population and then stratified by race. So in the very first study, we restricted to women diagnosed with endometrioid tumors. And so you'll recall from the earlier slides that this is like the most common subtype of endometrial cancer. And typically women who have low-grade endometrioid disease, they do pretty well. But anyway, we observed that over 70% of women received guideline concordant treatment regardless of race, which I think is actually quite good. In terms of the adjusted models, we observed small but significant differences in guideline concordant treatment receipt. So hopefully you can see this, but namely, we saw that Black and Latino women were less likely to receive guideline concordant treatment compared to white women. And then one thing I guess I should mention here, actually, you know, I said before that like my work hadn't always employed the National Academy of Medicine framework. And so with that framework, you typically wouldn't adjust for things like income or any marker of socioeconomic status, but here we did adjust for income and county level. So basically county level information on education and income. And so with the National Academy of Medicine definition, you wouldn't adjust for these things because then basically you're saying that it's like okay that the healthcare system treats people of different income and education basically differently because you're absorbing some of the race effect when you adjust for those characteristics. And we can come back to that if that's confusing at this point. But so these are just the odds of receiving guideline concordant treatment. The take home, Black and Latino women were less likely to receive guideline concordant treatment than white women. And then in terms of survival, this shouldn't be a shocker, right? But we observed that lack of guideline concordant treatment was associated with worse outcomes. So the hazard ratios here are from both unadjusted models and then models adjusted for age, comorbidity score. I think we adjusted for facility character. We adjusted for a lot of things in this model. But basically what we're seeing here, so this is the very first red box. This is overall. And so you're seeing that women who do not receive guideline concordant treatment have a 12% higher risk of death compared to those who did. And then we saw similar patterns for women. So this is non-Hispanic white is the next group. Saw a similar pattern for non-Hispanic Black women as well, although you can see that the lower confidence, that the confidence interval includes 1. And then we did not see findings for Hispanic and Asian women. I'm not sure if, I mean, I feel like it's probably a little bit, well, maybe I won't speculate here, but we did not see associations for those two subgroups. Okay, so this is different. So in the second analysis that we did, basically we just restricted to women with non-endometrioid cancers. So again, these are the really aggressive cancers. They're more common in minority women, and they're quite deadly. And so in this study population, we had about 30,000 women with these tumors. And then across the board here, you're seeing, so if you look at these proportions, right, like 43.8%, 44.2%, we're seeing really low proportions of receiving guideline concordant treatment across all racial and ethnic groups. And so here, we actually don't see a difference in the odds of guideline concordant treatment by race. And so one of the things that we discuss in this paper, so one of the clinicians that I work with, this was his hypothesis, which I thought was really interesting, is that the overall low prevalence might be a consequence of the lack of clinical trials that focus on women with these tumors. And so he was suggesting that, well, maybe like we just generally, like, we believe the guidelines less because there haven't been so many trials, and so there's more variability in what we all do, and so that variability leads to low levels of guideline concordant treatment. And so basically just that there's a lack of evidence to reliably inform the treatment guidelines. But all to say, what was interesting is that in terms of overall survival, we still did observe that receiving what was called guideline concordant treatment, it was associated with better outcomes among almost all subgroups of women, but including white, Black, and Latino women. So you can see here there's the hazard ratio is less than 1, but we did not see the same thing for Asian. And I should have mentioned this before. So we actually grouped together Asian and Pacific Islander women, which I think is a consequence of how we used to like categorize women of those in those groups before. Like now I disaggregate, I don't include those women together in the same group because they are very different. And yeah, I think that it always becomes an issue of numbers, but I think like we're obviously moving away from looking at like white, non-white, right? And so like you want to add more granularity to your work. But I'm always embarrassed when I see that because I'm just always thinking, oh, I can't believe we grouped these very different groups together. But all to say, so in addition to the work that our group has done, which is pictured on this slide here, so 2 other studies have evaluated disparities in receipt of guideline concordant treatment, and their results are in line with our findings. So here again, I'm showing you the results from the WHI paper first, and then also from the endometrioid NCDB study, and then from the non-endometrioid NCDB study. Again, I have the caveat here that perhaps we're not seeing differences because the guidelines are potentially flawed in terms of the evidence that's used to support them. But anyway, in terms of the other 2 studies that have been done, we see similar lower odds of guideline concordant treatment among Black women. And then this is the 5th study that was conducted. And basically the take home here that I want you to have, even if you're not going to remember all those numbers, because why would you, but guideline concordant treatment is lower among Black women diagnosed with subtypes where, quite frankly, well-established treatment guidelines exist. When I talk to clinicians, they say, well, we do know how to treat women with the low-grade endometrioid tumors. They know a bit more about the high-grade endometrioid tumors. I think that, those tumors are most likely to have local regional recurrences. And so like radiation does tend to work pretty well for those women. But for the non-endometrioid types, again, what I'm gleaning, I'm not a clinician, but what I think I understand is that the guidelines are not potentially optimal. Okay, so then I just want to summarize the survival analyses. Again, like I feel like what we're doing is not rocket science. Of course, we would expect that survival would be better if you're receiving the appropriate treatment that's recommended by guidelines. But basically, in terms of survival, the main story is that receiving guideline concordant treatment is related to better survival. There's just been 1 additional study that has looked at this in SEER and reporting similar results as ours. So again, take home here is that regardless of the histology, receipt of guideline concordant treatment is associated with improved survival, and we should expect this. Okay, so I get really tired when I present, but try to keep my energy up. But switching gears a bit, so our team is generally interested in understanding mediators of racial disparities in survival that might operate through treatment. So you'll recall from the National Academy of Medicine framework that patient preferences are an allowable source of difference in treatment, but people really don't love this interpretation from this framework because you might suspect that people form their preferences for treatment based on their interactions with the healthcare system, right? So if you're in a group where you feel like you have not been treated equitably by providers, it might be your preference to forego coming in daily for radiation because you don't want to have those interactions. So people really don't love that ends up in that allowable sources box. And so yeah, I thought that was, I wanted to pursue that more, looking at treatment refusal as a proxy for patient preferences. I don't think those are the same thing exactly, but we're able to look at treatment refusal in the National Cancer Database. So treatment refusal is commonly cited as a reason why minority cancer patients receive treatment at disparate rates. It's not that minorities, and I think that does play out in the literature that that they refuse treatment at higher rates. And some of the reasons why this might be is because of distrust of individual providers and the US healthcare system, skepticism about their diagnosis and prognosis, compromised healthcare literacy, and lack of satisfaction with physician communication. So the study that we undertook did not explicitly address any of these factors, but we explored the extent to which refusing recommended treatment impacts survival among women with endometrial cancer. And here specifically, we did not, it was too challenging to try to code for recommended guideline concordant treatment because of trying to group together those variables for radiation and chemo. I feel like I could have gotten there, but it was so challenging. And so we ended up just looking at whether or not women refused radiation or refused chemo. So the research questions here were, among women recommended to receive radiation or chemotherapy, are Black women diagnosed with endometrial cancer more likely than white women to refuse? And then does treatment refusal mediate racial disparities in survival? So this is super straightforward. In logistic regression analyses, among women recommended to receive either radiation or chemotherapy, we saw that Black women were more likely to refuse chemotherapy with an odds ratio of 1.26, but there was no difference in refusal of recommended radiation treatment between Black and white women. And again, this is just among the subgroups who were recommended to have that treatment. So we also examined the joint effect of race and refusal of treatment on overall survival using Kaplan-Meier survival curves and log-rank tests. So you can see that white women who, so on the left, we're showing the joint effects for radiation, and on the right, we're showing the joint effects related to chemo. And so you can see that white women who received radiation, hopefully that's kind of clear. So white women that received radiation had the best survival trajectory, while Black women who refused radiation had the worst survival trajectory. And I think what's really interesting about this graph is that white women who refused radiation, they had a similar survival trajectory as Black women who received radiation. So I thought that was a little bit interesting. Obviously, there's something going on like in terms of the curves crossing, but definitely interesting patterns. Similarly, for chemotherapy, we observed that white women who received chemotherapy had the best survival trajectory. Black women who refused had the worst survival trajectory. And then again, we're seeing like basically white women who refused chemotherapy had better survival than Black women who received chemotherapy, although there's a crossing of curves around 10, around like 120 months, like 10 years, we're basically seeing that there's a crossing of the curves. Okay, so getting to the really interesting part of this analysis. So for the mediation analysis, we used accelerated failure time models with a Weibull distribution. And I'm going to pause for a minute to say that I work with a really smart statistician who we do all of our work together, and she does all the analyses. So I probably won't be able to answer a ton of questions, like technical questions about this model, but she recommends this for mediation analysis, particularly when, in Cox proportional hazards models, there are certain assumptions, and some of those assumptions really they're not likely to be held. And so anyway, we use an accelerated failure time model. And so the top portion of this table is women who were recommended to receive radiation. And then the bottom portion is women who were recommended to receive chemotherapy. And so focusing on the radiation results, we're showing the association in the overall study population. So you see all patients. And then we also did this stratified by histologic subtype. And then again, really just the same thing for a subgroup of women who were recommended for chemotherapy. And so I'm going to focus where we saw significant mediation effects of the association between race and overall survival. And so for women who were recommended for radiation treatment, we observed that refusing radiation treatment was a significant mediator among women diagnosed with serous tumors. So here we're showing, so here we're showing, so for that first row that's highlighted, basically the total survival difference in months is 12.3 months. So on average, white women survived about a year longer than Black women. But the next column over, you're seeing the causal mediation effect, right? So of that 12.3 months, 0.88 months are related to refusing radiation. So really it's the percent of the relationship that's mediated is 6.9%. For chemo, I'll just do one of these. I'll do the overall. So here you're seeing that among women who are recommended for chemotherapy, the total survival difference is about 42.6 months. So on average, white women are surviving 42.6 months longer than Black women. But of that, about 1.11 months is attributed to refusing chemotherapy. So about only 2.6% of the relationship is mediated by refusing chemotherapy. But then you can see for women with serous tumors, about 7.3% of the relationship is mediated by refusing chemotherapy. All to say, like, so if we're adding this to our conclusions, we can say that racial differences in treatment refusal exist, but we sort of we speculate that it mediates a small proportion of the survival disparities between Black and white women. And so again, here, I think it's what we're trying to do is really to understand, like, what are the root causes, and so that we can more appropriately, well, if we're going to have an intervention to reduce refusal, then we might understand, like, how survival would ultimately be changed if that was the intervention that we chose to target. What do you think, Jamie?
Oh, okay, no.
Rachel, okay. No, so to this point, I've presented what we've done in this area so far, and of course, there are really important gaps that remain in our understanding of why Black women receive guideline concordant treatment less often than white women. And I think it's also important to say, I mean, I know that I focus specifically on white-Black differences. You saw that the Hispanic women have lower rates of guideline concordant treatment. I think that there are other groups for whom this is important, but I guess I really focus on the Black-white differences. But anyway, the body of literature, which includes work from my own group, we've really focused on the individual level determinants of these disparities, which is important, but it also ignores the broader context in which Black women are born, grow, live, work, and play, so the social determinants of health. And so, you know, I think that this kind of narrow focus has really limited our understanding of the pattern of what's going on here. Second, these studies have been done mostly using cancer registry data, which I think lacks the type of specificity that we want related to characterizing guideline concordant treatment. So here I'm telling you that I really think that there's misclassification in the way that we're coding these variables, but I think it's also a real problem related to the cancer registry data. And finally, there are no qualitative studies that focus on Black women's experiences with treatment from their own perspective. So really the voice of Black women is missing from the literature. And so what are we going to do about this? So to address these gaps, our group, we received a newly funded grant from NCI to identify multi-level factors predicting Black-white disparities in guideline concordant treatment, and also to quantify disparities in the intensity of guideline concordant treatment, which I haven't really talked about that at all, but I don't know if you remember from that picture that I showed, there's a range of options that are guideline concordant, but you can, so for example, maybe it would be guideline concordant for a woman to have chemo and radiation, or she could just have chemo, but there's something different about having chemo and radiation. You might suspect that that's more intense treatment, and if you think that, like, there's some sort of proclivity for people being pushed towards one paradigm versus the other, it could lead to differences in survival outcomes that are kind of masked if we're just looking at guideline concordant treatment, yes, no. And so the clinician that I work with on this, she was, like, very interested in looking at intensity, because she said, I don't know which is better, right? Like, there are these range of options, like, what should I be doing? And so that's why we put that aim in there. And so then I hadn't showed you the aim, sorry. The goal of AIM 3 is to examine the decision-making process among Black women using qualitative methods. So we think that that's going to be super interesting in trying to think about future directions in which we want to go. For AIMs 1 and 2, the reason that I have leveraging SEER Medicare to address gaps, we're going to be using the SEER Medicare data set to address those aims. And then really quickly, I feel like the two main ways that use of SEER Medicare is going to improve on the existing body of literature is through, first, the characterization of guideline concordant treatment, and then, of course, leveraging the multi-level nature of the data set to determine the effects of provider and structural determinants as contributors to racially disparate guideline concordant treatment. Okay, so normally in cancer registry studies, radiation and chemotherapy are coded as no versus yes, but I feel like there's a lot of heterogeneity in that yes group. Does that mean yes, a woman, received daily radiation for 5 weeks, which is what's recommended? Or did she, have radiation every other day and then she stopped coming after a week? Like that woman, she's probably undertreated, but I suspect that she's coded as like, yes, as having radiation and cancer registry data. It's not entirely clear to me, and I feel like that should be like clearer to researchers how like that, those variables are constructed within SEER, but all to say this data will allow us to look at those things, which is really cool. Let's see here. And then in terms of the second way that I think that this study is really going to make an improvement on the existing literature is, again, we know that health disparities are entrenched in the social determinants of health, and we really can't assess disparities effectively at the individual level alone. So in SEER, we do have some individual level characteristics, I think, that get at provider and structural level determinants. There's some census level indicators, but SEER Medicare is inherently a multi-level data set with the linkage to the geographic area data. So linkage to the American Community Survey, as well as the health referral regions data. And so, we specifically want to address the hospital referral region data. We specifically want to look at hypotheses related to, percent of the neighborhood receiving welfare or percent female headed households, trying to understand the larger context which might be driving some of the disparate treatment. So I promise this as well as my second to last slide. But again, ending with the framework that I started, I think it's like really important that we have rigorous and nuanced definitions of disparities. I'm not saying that we all have to use the same exact definition, but I think that it does lend itself to like really understanding what are drivers of disparities versus the things that are just different between women that actually aren't causing disparities. This definition, though, it does have analysis implications. And so similar to others that have employed the National Academy of Medicine definition, we also are going to use nonlinear extensions of the Blinder-Owaka decomposition methods to identify the proportions of racial disparities and guideline concordant treatment due to individual level factors, provider level factors, and then structural factors. And then of course I work with an awesome team of people. So I'm not gonna go through all this. So these are the people I work with, they're all amazing. You need a strong team, I think, and I'm happy to take questions and all of your amazing thoughts. So yeah, thank you. Suggestions or whatever you think. Yeah, hi.
Have you looked much into like second and third line treatments?
No.
Because I would imagine that guideline concordant treatment would decrease.
Yeah.
I mean,
I think so too.
yeah.
Wow, that's something. It's Wild West when it gets to, like the second and third.
Yeah, well, but I think that would be really cool.
Yeah. Do you have a sense of I guess it would be based on time then, like how you would denote that with claims data, right? Like the dates of which women are
Yeah.
receiving. Yeah, that would be the best.
And then you just have to, I mean,
Yeah, we've used
what's the word I'm looking for? Radiologist? What is
Tyler.
Tyler?
He's a
Yeah.
radiation oncologist.
He gives us all the details on
Yeah.
medication guidelines and.
Like all of like the cycles or like lines of treatment, we've always like based it off of dates, which can get tricky too, especially when you like consider dosage. I think, so we've been using EHR data
Yeah.
for some of this, and
Yeah.
that also brings up another level of complication.
I've seen some HR papers recently, specifically looking at second and third line treatment. It seems like, yeah, there are trade-offs to both. And
Yeah.
what my PO was suggesting, like for a supplement, she's like, oh, you should like compare EHR data with like claims data. I'm like, but anyway, it seems like logistically like a nightmare. I don't know how, but
Yeah, I mean, I think when after playing around with some of the EHR data, I think we've realized having some kind of, like obviously with claims data, there's a financial incentive to like record everything and have like, really nice like data recorded. But like cancer registries on their own, like you said, with like how things are recorded maybe by the registrars, it could be like a lack of documentation why we're seeing certain patterns.
yeah.
So I think we've realized that EHR with claims, if that were somehow able to happen, or cancer registry with claims, seems to be like the best way to go, just because it's so hard to capture that treatment data.
Yeah.
But that's a big part of it, especially when, you're looking at concordance to the NCCN guidelines and
Thanks. Do you guys want to be on our team?
Yeah.
That's great.
I have a question on that, and then a comment. The SEER Medicare 65 plus, right?
yeah,
Okay, so you're
yeah.
limited to that group.
Yeah.
So are there, so maybe questions related to this. Are there differences in age at presentation between your Black and white groups?
Yes.
And then I appreciate your comment about there's a lot of ways to slice and dice disparities, right?
Yeah.
Finding them. So
Yeah.
the thing that sticks out to me is that Black women are more likely to get pretty aggressive types of endometrial uterine cancer.
Mhm.
And why? We see the same thing with breast a little bit, right? So
Yeah.
there's more aggressive types. Are you starting to look at risk factors? Is it just genetic? Like,
Yeah.
you may not be looking in that space,
Yeah,
but in terms
yeah.
of disparities and looking more upstream in terms of what's causing these things,
Yeah.
just a question.
No, it's a great question. I mean, I feel like this is the holy grail. Like, so one of the E2C2 studies, I think Linda, you might have been a co-author. I don't think I was. It was risk factors among Black and white women, right? And you don't see a difference in the magnitude related to, say, obesity and risk of low-grade endometrioid or risk of serous, whatever it is, between Black and white women. The magnitude of the effect is the same. I would argue that like the proportion of some of these risk factors is higher in Black women, right? Like the prevalence of obesity is higher in Black women in this country. I think really, so I'm applying for sabbatical, and like one of the things I'm super interested in is like environmental factors and how that might be related to risk of these different subtypes. And so that's like, I want to learn more about like environmental justice, environmental racism next year, and then also try to find data. Like I'm thinking of a Southern Community Cohort study or something like that to try to like tease apart some of these questions, because I think like the where you live part is like really not well understood for endometrial cancer. And I do tend to like borrow a lot from breast cancer. I try to like see like what are they reporting and how are they going about this. And I feel like we're talking that, you know, Alexandra White just published a big study in JNCI looking at like air pollution in relation to breast cancer, right? And so we know that there are differences in where people live in terms of pollution. And so anyway, I don't have a good answer for you because it's like very confusing in terms of like when you look at risk factor associations, magnitude of risk is similar. In terms of genetics, I mean, I can't probably speak to that as well as others. We definitely know that like even beyond the histologic subtypes, there are differences in the molecular subtypes that have been identified through the Cancer Genome Atlas study in terms of like who develops the different molecular subtypes in terms of race. But I mean, I feel like it's like an underexplored area. Like we really need to move away from like hormonal and reproductive risk factors for this malignancy and try to understand like other potential causes of these.
Yeah, because you have to make the case that environmental exposures affect two groups differently.
Yeah. Well, I also think
So, I don't know how that affects tumor biology. So that's kind of where,
yeah.
I mean, this is not the only cancer where this is a question.
Yeah.
But
Yeah.
I'm just curious what your thoughts are on that.
Yeah, I mean, I don't think that this country is as segregated as it used to be, but I do think that like minorities do tend to live in areas where there are different exposures. And so even with environmental exposures, I think like even if like in Alexandra's paper, I think she showed like an odds ratio of like 1.10, but she was like, that is a small, so I mean, it was a relative risk. That's a small relative risk, but air pollution is a ubiquitous exposure for certain populations. And so, I don't know, this is a really good question. Like, I really appreciate this conversation because it's just, I don't know, it's making me think about things that we really need to be doing and just need more time. Thank you.
No, really enjoyed your presentation.
Oh, thank you.
So I have a technical
Yeah.
question, of course. You always looked at overall survival.
Yeah.
And you never did endometrial cancer specific survival. And I certainly understand that most of these women are not dying of their endometrial cancer, right? So most of them are dying of something else. And so you could, if you did this though, you might see, just given the characteristics that you have presented on stage and histology, you might expect an even bigger difference between Black women and white women in terms of endometrial cancer specific survival. Did you just do this because of low numbers? Is this the
Oh, no.
issue or what's the
Yeah.
reason you chose that?
And
Just curious.
No, yeah, no, it's great. In National History Database, they do not have cause of death. So, but we are definitely looking at endometrial cancer specific in Senior Medicare, because they have cause of death. So in a new grant, we'll definitely tease this apart. Cause I think you're right, like I think that,
I think it's gonna be even worse, quite
Yeah.
frankly. That
Yeah.
would be my prediction,
yeah,
right?
yeah.
Good, glad you're
Yeah,
doing it.
yeah, no,
Thank
National
you.
Cancer Database is great, but yes, the overall survival, like no recurrence, no cause of death, that's the big limitation.
Yeah.
Good, yeah, yeah.
For the qualitative portion
Yeah.
of some of the upcoming work, have you guys decided how you're gonna recruit patients, what population?
Yeah, so the primary site will be Ohio State, and then Kemi Dahl is a researcher at the University of Washington. She has an advocacy group that she started called ECANA, hopefully I get the whole thing right, but it's the Endometrial Cancer Action Network among African Americans. And so we'll recruit from Ohio State, we'll recruit from UW as like the academic institutions, and then we'll also plan to use her network in ECANA to try to recruit survivors. What are you thinking? Yeah.
No, I do some care planning qualitative research here at UC Health, and we do it at a lot of our sites, and I just have been surprised, I think because it's single site, the variability in the responses are not what I thought they're gonna be, even though we do all solid tumor types.
Yeah, yeah.
And people just seem to like have a lot of faith in their clinicians and not really question them as much
Oh,
as I
interesting.
thought. And so I was curious if it was gonna be single site as well, because I think the credibility of the institution, people put a lot of faith
Yeah,
and don't question their clinicians as much as
Yeah.
I would have thought.
I agree. I think I feel like it'd be really interesting to see like, differences between the women we recruit from the academic centers versus ECANA. I also didn't mention, because it was in the revision for the grant, they were like, oh, well, you need to also look at providers. And so we are gonna have a provider interview at some point to like, we're gonna try to like recruit people from SGO and try to do something there. But I also feel like it makes a difference whether people are providers at community-based versus, I feel like there's gonna be a lot of work that Black gynecologic oncology female providers versus, anyway, I think there's a lot to tease out. But yeah, thank you for that comment. Yeah.
I think like kind of going further from that and also attaching into the clinician side. So we're doing work right now where we're also interviewing clinicians as a part of a qualitative. And like one of the things, and I'm sure you guys have thought about this too, is that, you know, it's how much time are you spending with these patients? And then if you're not spending as much time with patients, like having a big enough sample size of clinicians so that you are still getting that group that you want to speak with and like learn from.
Yeah.
Because like I'm sure there are other perspectives that you're gonna want to like encompass in. Maybe thought about like other than people who are seeing patients like for those solid tumors or otherwise like on a more regular basis, like how much of that clinician base would you want to like access at both institutions or more, or is that just like a, you know, kind of spiraling forward question?
Yeah, no, that's a really good question. I don't actually suspect that, I don't know that many clinicians at our institution will participate, like we'll send it out to like so SGO is like the Society for Gynecologic Oncology, it's, you know, they're a big organization. And so the groups that we said we wanted to target were people who worked in community settings versus academic. We talked about, we really wanted to get a good group of women versus male providers. But your point about like, like how much people, that might be like a question that we ask, like we're gonna have like a short like survey that's not super related to the questions that we really want to glean, but like, yeah, on average, how much time are you spending? I think that's a really important question. And I think one of the things we want to assess, and I think it's like kind of a little bit weird to try to assess like provider knowledge, but like we suspect that like, well, there might be like a gradient, right? Like people who are in the field longer, maybe they don't follow the guidelines because they're not now using minimally invasive surgery. Like they might not still be using like open laparoscopic procedures. But then I could also see like there being a sweet spot of like providers who've been like working in this area for a long time and they're better equipped to follow the guidelines. I don't know. There's a lot to, so we're in year 2 of the grant, but I should be making more progress by now. But these are all really good. Like,
I know, I hate talking about active grants.
I know.
So we're behind, but the one question I have, and I promise to let you go because we're over, but
Are we over?
yeah, you use NCCN guidelines
Yes.
as your gold standard. Does SGO have other guidelines, treatment guidelines, or other guidelines, or NCCN the only guideline out there
Yeah, no,
to determine concordant care.
Yeah, it's not the only, so it would be SGO, ACOG, and then NCCN, so American College of, yeah, so all three of those. And, well, you know how it is, like, they slightly differ, and so sort of, maybe it's not arbitrarily, but like, I've always focused on the NCCN guidelines.
Mhm.
And I've never gotten pushback from the clinicians that I work with, so, I don't know, I mean, yeah.
I have no
The-
dog in the
the-
fight, I was
that's-
just wondering if
Yeah,
there's.
the differences are
heterogeneity.
minor though, between the three, you know, it's not like screening guidelines, that
Right,
can
that-
vary
that's-
widely
that-
between the, yeah.
That was where the
Yeah.
question was
Yeah,
coming
yeah,
from,
yeah,
because the
yeah.
NCCN screening guidelines are like off the rails.
Yeah.
Bizarre.
Yeah,
Because
yeah.
they're all oncologists and they, you know, wanna screen for everything.
Yeah.
Versus the Preventive Services Task Force, which is
Yeah.
very data driven.
Yeah.
And so there's heterogeneity there, but I was wondering about that level of heterogeneity.
Yeah.
They're
and
not
the-
that different,
That's
but
good,
this
yeah.
particular cancer,
Yeah.
it's pretty minor.
Right, and I think that the guidelines themselves change infrequently over the duration of time that we're gonna be like, the case diagnosis
Oh, that's
years,
nice.
so there's
That's
like
nice.
3 major times when it changed, but luckily, we're capping it at 2020, so before like immunotherapy is like entered the scene, because
Oh.
I don't know, we're not including that. Like, it's not part of the guideline concordant treatment up until a certain time point. So I think that's another grant, but,
I think uptake's been pretty low
Yeah,
for
I think so.
endometrial cancer and for immunotherapy.
Yeah, I was gonna ask about like changing, because we're looking at some sites where it's like, it's like the guidelines can change like every 2 years.
oh,
And so it's, yeah, it's wild.
yeah, it's like, you're coding it spot on, right, and yeah, so.
Well, your disparities might be even worse when you do the immunotherapy.
Yeah,
Because of economics and where people receive their care.
yeah.
Because some of our colleagues have done that in lung cancer and shown rural urban disparities in immunotherapies.
Yeah.
So, sorry.
Yeah. Thank